Welcome to Pharma. Opioid toxicity. The therapeutic and toxic effects of opioid are mediated through similar receptors, which include mu, kappa, and delta receptors. The overall effect of opioid is ranging from mild pain relief to coma with respiratory depression. To better understand this is by looking at the dose response curve. As the dose of opioid increases, the response increases. With a low dose, the patient gets mild pain relief, nausea, and constipation. Once the dose is slightly increased, the patient will get moderate to good pain relief, sedation, nausea and vomiting, and constipation. Once we increase the dose over again, the patient starts to experience great pain relief, respiratory depression, and more severe GI side effects. With high doses, the patient may end up with no pain, coma, mechanical ventilation, and even death. The main presenting features of opioid toxicity include central nervous system depression, which refers to a decrease in the brain's activity. When the central nervous system is depressed, various bodily functions that central nervous system regulates will get depressed as well. It can result in symptoms ranging from mild sedation to severe sedation and coma. The second presenting feature is respiratory depression. Opioids can diminish the brain response to carbon dioxide, leading to shallow and slow breathing, reducing breathing rate, and this can lead to hypoxia and, in severe cases, respiratory arrest. Opioid-induced sedation can potentially increase the risk of aspiration, leading to aspiration pneumonia. Non-cardiogenic pulmonary edema is another complication of opioid overdose. The main etiology behind it is that increased vascular permeability and endothelial dysfunction. Opioid overdose also affecting the eyes, causing pinpoint pupils, which is called miosis. Also affecting the cardiovascular system, causing QRS widening, which is mainly caused by dextropropoxyphene, and Q2 prolongation that's caused by methadone. Serotonin toxicity is mainly caused by atypical opioid overdose. Atypical opioids are both mu receptor agonist plus noradrenaline and serotonin reuptake inhibitor. For example, tramadol with a greater extent and tapentadol with lower extent. Treatment of opioid toxicity in the pre-hospital setting is important to save the patient's life before reaching the hospital. Naloxone nasal spray is an opioid antagonist that reverses the effect of opioid ingested. The dose is one spray into one nostril and, if needed, another spray into another nostril after 2 to 3 minutes. Intranasal naloxone is as effective as injectable naloxone. Intranasal naloxone had a slightly slower onset of action, and the odds of needing a rescue dose was greater than with intramuscular or IV naloxone. For the treatment in the hospital setting, the aim of therapy is to reverse hypoventilation and increase the level of consciousness to protect the airways. Supportive therapy is crucial for the airways and breathing. The patient should receive adequate oxygen therapy and ventilatory support. For cardiovascular system, continuous ECG monitoring is important. Decontamination is not often used in practice due to the risk of aspiration and the availability of antidote. However, activated charcoal is sometimes used to reduce the duration of toxicity for slow-release tablets and long-acting opioids like methadone. It can be considered if slow-release preparations was taken within 6 hours in non-sedated patients and after 1 hour of ingestion for methadone overdose. Antidotal therapy is the cornerstone treatment for opioid toxicity. Initial dose is 400 to 800 microgram intravenously, intramuscularly, or subcutaneously, repeated as needed. Subsequent doses should be guided by pupil size and clinical response. For IV administration, the dose should be titrated every 2 to 3 minutes and up to 2 milligram. The patient should improve in 1 minute. Reconsider diagnosis if no improvement after a total of 10 mg has been given. For most overdoses using short-acting opioids, only 1 dose of naloxone is required. For long-acting opioids, a naloxone infusion is usually required after the initial bolus dose.